Future for All, which is being held in partnership not only with the NMA, but the blackdoctor.org, Pfizer, and Charles Drew University of Science and Medicine. So I'm so pleased to see so many faces out there, and I'm looking forward to building some new relationships today. So we want to thank you all so much for being part of this important moment together. Never have we realized, I'm sure, in planning for this conference, that we'd face the next challenges that we're facing now. And I say this because 2 nights ago at 9:30 p.m., I received an email from my State Department of Health stating that my funding for all my immunizations program will stop immediately at 9:30 p.m. And so $13.1 billion has been removed in one night from state and local health departments across the country. This is serious. So you're going to find in this next 2 hours, you can expect some riveting dialogue from leading organizations and professionals about workforce development and 340B pathways. So I want you also to please stay after for our networking reception. I want to meet some new faces. I want to hear some new perspectives, and I want to know what's going on in your local communities and what your issues are. So today's summit is just the next step in the Pfizer Multicultural Health Equity Collective. You'll see a QR code on your tabletops. So if you can please click on that now, we would appreciate it. And I also want to give just special thanks to Pfizer for your leadership related to this. We are grateful to our partners at blackdoctor.org, who ensure that we always have the latest health and wellness, not only how to do it, but you can do it content. And so now, at this time, I'd like to welcome Ms. Nisha Foster, who's the Vice President for Global Health and Social Impact and Co-Chair. Ms. Foster.
Thank you so much. So good afternoon. I am Naisha Foster, Vice President of Global Health and Social Impact at Pfizer. And also I have the opportunity to co-lead the Multicultural Health Equity Collective with Melissa Bishop Murphy. So what does that all really mean when we talk about social impact? I have the privilege of overseeing Pfizer's portfolio of global product donations. So we have a strategic approach to how we think about our role in health equity, and it's focused on closing the gaps that are in product access, closing the gaps in information, and closing the gaps in funding. Thank you for joining us here today at the Pathways to a Healthier Future for All Summit. This collaboration between blackdoctor.org, the Multicultural Health Equity Collective, and the National Medical Association represents our continued efforts to address pressing healthcare challenges today, not on our own, but through partnership. These systems and practices that exist today are operating exactly as designed. And it's only through partnership with organizations within the healthcare ecosystem and across industries that we will get out of where we are today. While many of you may know Pfizer, you may not know the Multicultural Health Equity Collective. So the collective, as we call it, is a cooperative of 40 plus non-for-profit US-based organizations, as well as our Pfizer colleagues who are passionate about closing the health equity gap. We've partnered with medical organizations, legislative, and community-based organizations on a number of things. To give you a couple of examples, we have had Spanish language pilot radio programming to raise awareness of the importance of oncology screenings, vaccinations, and other healthcare priorities. But it wasn't Pfizer people on that radio program. And as much as I think my New York Spanish is going to be helpful, it would not have been in that forum. But it really was partnering with trusted voices in the community who are bringing information every day to those populations. It was also making sure that materials that we were providing were culturally relevant and appropriate. With our partners, we are thrilled to be doing this work in the collective for 11 years now, and we have no signs of stopping. And we have no signs of stopping because we know that there are still disparities that are preventable that we can help to solve, and we will continue to do that work. To disrupt these biases and roadblocks, quality of care requires representation and leadership at all levels, from the lab to the exam room to the boardroom. And that's why we are here today to highlight for you a guide that was developed not by ourselves, but in partnership with over 30 different organizations who have worked with us over this decade. And they said, we know what we're doing in the community. We want to find a way to amplify those solutions that are working well. Those solutions that are in the policy area, healthcare delivery and facilities, also in workforce pathways, which you'll hear about later on today. So today's summit will focus on two areas in the guide. And thank you, Dr. King, for highlighting the QR code. You'll hear about a panel on workforce pathways, and then also on an important policy priority. Now, I believe these panels will be informative and hopefully spur you to act. We're not just here to be with each other and feel good. We're here to make sure we get something done at the end of it. And so if you don't learn something or you're not spurred to act, please come speak with me later because we've done something wrong and we want to correct that. And now to help focus on delivering those two goals today, I'd like to introduce you to our esteemed moderator, Melissa Bishop Murphy, who will bring up her first panel on workforce pathways to a healthier future for all. Melissa?
Will the panelists for the first panel please come up to the stage while I make a few introductions? Well, good afternoon, everyone. I would be remiss in also not mentioning the National Minority Quality Forum, which is also a partner with us this afternoon. So we're happy that Dr. Gary Puckering will be on the second panel. So as the panelists come forward, let me just start with some brief introductions around this topic of workforce pathways. We all know the shortage of physicians and healthcare workers has reached a critical point. These shortages are felt most acutely in underserved and under-resourced communities where access to quality care is already limited, leading to poor health outcomes and widening disparities, something you know a lot about. To address this crisis, the healthcare industry must embrace workforce innovation, ensuring a steady pipeline of skilled professionals ready to meet the growing demand. One key strategy is the expansion of pathway programs, which guide students, especially those from historically excluded backgrounds, through the educational and career steps necessary to enter the healthcare fields. By investing in these programs, we can cultivate a new generation of healthcare professionals equipped to serve where they are needed most. The Health Equity Collective is working to address those barriers. We know the need for workforce diversity is well documented. Black and Latinx physicians make up only 5% and 5.8% of all the physicians' workforce, while Black and Latinx nurses represent just 6.7 and 5.6% of the nursing workforce. Research has shown that when patients receive care from clinicians who share their racial or ethnic background, their experience it leads to improved trust, satisfaction, and of course, better health outcomes. And so that's a testament to all of you in the room. So, you know, this panel will, It seeks to explore these challenges in depth and bring together experts, here they are, to identify actionable solutions that will help create a more diverse and representative healthcare workforce and subsequently a healthier future for all of us. So we want to make this interactive. We want to not be us here talking to you. So will you pull out your cell phones and go to www.menti.com. And while you're doing that, will you pull up the code? So to make this interactive, we wanted to get some real-time information data from the audience. Are you at www.menti.com? If you are, please enter the code 14477095 and then press join. Yes, happy to do so. 14477095 and then press join. Okay, are you all ready for the first question? All right. So the question is, what is the biggest barrier to recruiting and retaining a diverse healthcare workforce? Is it lack of mentorship and career pathways? Limited financial incentives and compensation? Insufficient training and upskilling opportunities? Or is it early school experiences divert students to other pathways? Ah, okay. We might have a tie here between early school experiences divert students to other pathways, which is, frankly a shame. And so we'll talk about that, and limited financial incentives and compensation. Thank you for your attention to that question. So now let us turn to our esteemed panel and hear what they have to say. So panelists, in the interest of time, could you please introduce yourself by giving your name, title, and organization as you answer your first question, because we're a little bit late. So when I ask you your first question, please introduce yourself at that time. So Dr. Benjamin, we're going to start with you. Dr. Benjamin, we know that education is a social determinant of health. Why is education attainment so important, especially in under-resourced communities?
So, Dr. Georges Benjamin, I'm the executive director of the American Public Health Association. And there's a fascinating statistic that in every society that's ever looked at it, relationship to the mother's education to child survival in the first year of life is highly correlated. So more education, the better the child's going to do. And whether that's a surrogate for other things in society is not real clear, but it's a strong correlation to education. We also know that high school education for all genders is a determinant of better health outcomes. So, if you think about it, the fact that you are able to read, you're able to write, you're able to navigate society allows you to really be out in this world and do a lot of things that you wouldn't normally be able to do if you didn't have those attributes. So education is extraordinary.
Dr. Kane, I'm going to follow up that question with, according to the American Association of Medical Colleges, the United States will face a physician shortage of up to 86,000 physicians by the year 2036. That's just around the corner, right? Can you please share perspectives as to how we got here? We just heard from Dr. Benjamin, but how did we end up with this huge shortage that we're going to face?
Well, I'm Virginia Kane, and I'm the Director and Chief Medical Officer for the Marion County Public Health Department. I'm also an Associate Professor of Medicine in the Division of Infectious Diseases at Indiana University School of Medicine, and I practice out of the 5th largest public health hospital, Askenazi Health. So one of the things we want to think about is that, we get a lot of training dollars for training medical students and residents. So 2023, we graduated 43,000 medical students. But when you look at the residency training programs, we only had 40,000 slots available. So that means almost 4,000 doctors, they can graduate from medical school, but they can't get the necessary training in order to pass the examination to practice medicine in our states. Now, the other issue that we have is that, we used to have this wonderful program that, especially those rural communities where they might not have a hospital, maybe the closest hospital is 150 miles away, and there's no federally qualified community health center nearby, to attract physicians in those areas. If we gave you a full ride scholarship, in return, you would have to practice in the physician shortage area somewhere between 3 to 5 years. It was a great way how to pay off your medical debt, but go to locations where we had a shortage. And so those programs are disappearing. Our DEI programs are disappearing in terms of really trying to encourage people from a cultural standpoint of producing more doctors. But the other problem is our population is growing in the United States. We're not matching that population. We have not, since I want to say 1997, increased the slots for residency specialty programs. There's no training slot. It's not been increased since 1997. And we're even looking at the number of medical schools that are being produced and ones that have closed. We're not matching the need with the workforce shortage. And it's getting more expensive and more expensive than ever to go to medical school, dental schools, nursing schools. It's a problem.
So I hear an action item in terms of policy, in terms of making sure that there's an increase, since there hasn't been one since 1997, to increase those residency programs.
So definitely increase those residency programs. We have a cap. A cap was put. Only so much money could be used for residency training slots. Since 1997. So we need to raise that bar, increase that cap. We need more funding in order to meet the need. And understandable, with the COVID-19 pandemic, we had a lot of our healthcare professionals who burnt out during that process. It was so demanding. And because of the shortage of the workforce, it required a lot of people to be working overtime and additional work than they would otherwise not do it.
Thank you. Thank you, Dr. Kane. Ms. Contreras, your name, title, and organization. But we just heard from Dr. Kane. She talked about we need to increase those slots. How can we effectively engage private donors and philanthropists to secure increased investment in these workforce development initiatives? And if you can, even speak to engaging policymakers.
Yeah, absolutely. That's a wonderful question. And so Jeanette Contreras, newly minted founding executive director of the Organization for Latino Health Advocacy. I was invited here actually because I'm on the board of the Hispanic Society for Rare Diseases, which I am representing as well. However, I am excited to be here today and speak on this topic. I'd actually like to address some of this, just a little bit tag team on some of this earlier from the perspective of first generation
Absolutely.
Medical student, right? So now I didn't go to med school, but when it comes to barriers to entry into medical school, the cost of applying, not just being prepared and taking the right classes, right? Having gone to a school within a district that has the proper, college prep courses. So education is, Dr. Benjamin was mentioning, is really important. But when you're considering, first generation college students, the bar, the road is just a lot tougher because it's a more uphill battle for them to navigate student loans, right? And there are just not enough student loan repayment programs, like that wonderful program that Dr. Kane mentioned, there's just no funding for it. So I think that the way to incentivize philanthropies and private foundations to fund and resource that is by providing data and evidence that programs like that do impact the overall health of those communities that they serve, right? Every time one of those students goes to an underserved community and spends 3 years there, what is the outcome of that impact? And we don't have, I don't think, real data on maybe the number of vaccinations that person did, the number of screenings that happen, and how do we quantify that. And I think that for a lot of private foundations now, they're almost operating like businesses, right? You have to make a business case that this is worth the investment. And, we're not going to just do education and outreach. Now we want outcomes. We want to know how many people were screened, how many were referred to a specialist, were there telemedicine appointments. A missing piece there as well is the role of community health workers to help bridge that gap in the pathway. So where there are shortages of physicians, the community health workers often step in. And so I think the future is really thinking about this country as getting more diverse every day. I don't think that private foundations can ignore that the population is going to be more diverse, multilingual, and if we want to have a strong economy, there's the business case, right? Healthy communities build strong economies. And I think that that's a narrative that we need to start bringing into the conversation.
I totally agree with you. I really think that argument, not only for private philanthropy, is a great argument for policymakers as well. And so we'll talk a little bit about artificial intelligence in a minute, but you talk about getting that data to make the business case. I think that artificial intelligence may play a significant role in getting that data. So we'll explore that in a few minutes. Ms. Gottburn-Schubert, I have a question for you and to talk about the importance of our future healthcare professionals having some research exposure, right? So we heard Dr. King talk about that there are 4,000 medical students who don't get placed in residency. So can you talk a little bit about the opportunities that are available for those scholars at the Society for Women's Health Research?
Absolutely. So Catherine Schubert, I'm president and CEO of the Society for Women's Health Research. And obviously we talk a lot about research, and I think what you just talked about is a great opportunity for research, not just from a basic science perspective, which is really important and I think crucial if you are, in medical school or even thinking about becoming a healthcare clinician, to fully understand, what the data is behind the guidelines that you're practicing, what may be missing, but also asking these really important questions. So one thing I absolutely have to talk about, otherwise someone on my team will tell me that I missed an opportunity, is this issue of sex differences research. And so that's going to be, I think, even more important for clinicians in particular. So thinking about how are we conducting that research as a physician, what went into the medications, like what was the research behind the medications that you're prescribing, but also beyond that, right? The community health aspect of it, the implementation science. How are we getting these treatments and access and care to the people directly? So there's an opportunity there and a very important need for it. And I think to your point, right, about like private investment, that time is now, I think, we know what the federal budget is looking like. It's not looking good. And I think the funding for those programs, that Dr. Kane mentioned and all of the programs that Dr. Benjamin is working on, we're seeing that decline. And so it's time that, private philanthropic efforts really need to step up to be able to fund those. When it comes to research, I think there's a few different things that are preventing that from happening. Protected time being one. Who's got time to do all of this, right? When you're trying to just give regular care to your patients coming in and you're already overworked and overburdened with the number of appointments you have to give, right? I was at an event last week and an OBGYN was telling me she saw 38 patients in a day. That does not make for good care, right? It gives you very few minutes. So how are you going to conduct research on top of that? So I think thinking about policies that are in place or need to be put in place, institutions that can protect research time to really allow physician scientists to practice and fully understand kind of what's going on. And then I would say for us in particular at the Society for Women's Health Research, we're looking at how can we give travel grants to young investigators to go share their research in a variety of venues? And then the other thing, speaking of sort of private efforts, we really have sort of been thinking about how do we step up as an organization? We're very small, but how can we help researchers and physician scientists sort of bridge that gap with what they're experiencing right now. Have they lost their funding? Have they been told they have to stop doing something? How can we help just try to get folks to that next stage to be able to really thrive in their careers?
Are you all keeping a database of those entities that are losing their funding?
We're trying.
Mhm.
I think one of the challenges with that is really what's true and what's
Mm.
not true.
Mm.
It's hard to prove. What we are doing on the women's health side is we have pulled the information that we know, right, of programs that have either been stopped. We're hearing directly from researchers as well. So, there are opportunities. We have a form, but you can also reach out to us. Like if you're experiencing that, we would love to know so that we can help advocate for that to change. We can keep it anonymous. That's totally fine. We just need the examples of it. But it happens very quickly, as you heard Dr. Kane say, right? Like you hear about it and it's immediate. And then maybe it'll come back, maybe it won't come back. So we're sort of trying to catalog all of these things and see sort of what's missing, what was up publicly, what do we need to put up, and how do we access what it was that's missing? And do we know if it comes back up, what does that data look like? Like
Right.
those are really tricky questions.
Well, thank you for that. Dr. Benjamin, can you start a dialogue with this panel about the workforce healthcare challenges? And would love for others to speak to the priorities, where it should be, how do we prioritize all of these workforce challenges that we know about?
Well, I think the work has changed. There was a time when the physician went to school and frankly was the top of the pyramid, and you learned everything in the book, and then you went out and you practiced it, and there was evolving science, but it was evolving at a reasonable pace you could absorb. Now science is moving at the speed of light in terms of knowledge. So that's one problem. Second problem is the fact that we have, as a system, devised a system, what you just heard, where practitioners are having to see a new patient every 15 minutes. Now, when I went to medical school, you took a history, you did a physical exam. The social history could take 15 minutes. Those days are over. They've been gone for a long time. So I think the real challenge we have when we do that kind of thing is to ensure that, A, we have systems to maintain our knowledge, and artificial intelligence may help us with that a bit. And we can learn to apply that knowledge. And I think we've got to learn to work more in teams. For sure.
Totally agree.
That's one of the real challenges, because the day in which every patient got seen by the clinician, by a physician, every time they got seen in the office, those days are over. We need to work in teams, and we need to have team decision-making processes. We need to use physician assistants, nurses, and community health workers a lot more in our practices in order to do exactly what we need to do and allow everybody to practice at the top of their license. In order to do that, there's enough work for everybody and enough patients for everybody.
It's interesting that you say that, because I've been in, not directly engaged in these battles, but physicians are reticent to have others practice medicine, if you will. How do we allay those fears that, physicians have in regards to others practicing medicine?
Yeah, I remind me of Socrates didn't have a license either. And the fact of the matter is that we're extraordinarily well trained. But there are just so many things that I don't need to do.
Right.
And there are things that other people can do. And quite frankly, some have a better temperament for it. Some are better skilled at it. And I just think we need to get over ourselves that we have to do everything. Now, it doesn't mean you cannot lead the healthcare team. That doesn't mean you can steer, but you don't have to row and do everything. And the fact that pharmacists are giving shots is not going to break the medical profession. We need to do more and more things if we're going to be successful in doing that.
Thank you, Dr. Benjamin. I have to bring you into the States with me when we're discussing those issues. Dr. Kane, can you add on
Yeah,
to that?
I wanted to change the paradigm a little bit. I think that if we continue to do medicine in a traditional way, we will continue to have health disparities. We will continue to not be as efficient in terms of our outcomes because the traditional medical services doesn't involve social determinants of health. So if you're not addressing safe housing, you're not taking care of food insecurity, you don't know whether they're homeless. And wow, you think a homeless person is going to make all of those appointments to know to get on the medications if you're not addressing it? So we're the only developed country. We have twice the amount of expenditures per patient because we don't emphasize enough of the social services. It's more like a secondary, tertiary type of thing we do for social services and our social determinants. But all the other countries that are so successful with their health outcomes, they're almost on the same level of services. So in the 15 minutes, you think I have time to figure out that they're homeless? Are their electricity bills going to be turned off? Or, hey, they live by a gas station that has food market in there. That's the closest that they're going to get to a grocery store in maybe 5 miles. So we have to do the medicine in a different way. We have to have these resources available to us. In that education, hey, where are we community health workers? You know, a lot of work can be done from our offices with our patients, but a lot of hospital systems, fairly qualified community health centers, you know, we always expect the patients sometimes to come to us, but hey, we got to be progressive here if we're going to do a paradigm shift and really make a difference.
I totally agree with everything you've said. And so to that, Ms. Schubert, what we're hearing from Dr. King is really a community-based approach. Can you talk to us about some effective solutions to improving access to communities? It's particularly using maybe telemedicine, and certainly would love to hear about you all's legislative priorities, especially around community-based solutions.
Yeah, sure. I mean, I think we all have a lot of hope for telehealth. I think we saw, obviously, during COVID that was really instrumental. I know for me personally, I did a telehealth appointment with my daughter in my car outside of a Starbucks a few weeks ago. But I could get her from school. I couldn't get, an hour away to go meet with our adolescent gynecologist, and it was a follow-up. And so that really is truly a lifesaver when it comes to those types of conversations. So I think that's really important. I think it's a tool, right, of many tools. And when you talk about shifting the paradigm, Dr. Kane, I think that's spot on, right? You have to be able to really think about where are people getting their health care. Obviously, when we think about women and we think about moms, I know I get my flu shot at the pediatrician. They should get paid for that. They should get paid for screening, me for mental health crises throughout my lifespan, as they do screen for that. But how are we getting to people where they are? Is it through a community health center? Is it something that's not at all a community health center where folks are gathering? Are you all out in the community and meeting with them and talking with them and sort of finding out what's going on? So I think those are really important aspects of how we're sort of shifting the thinking behind where care is given and what that looks like. And, Dr. Benjamin, to your point, right? Like, you can go to your pharmacy and get your immunization. I know CVS is breathing down my back to get my shots all the time. And so just thinking about and that's a text. That's a quick text. So long as you have access to a cell phone, which is also an issue as well, right? Like, it only works if you have that technology. So really just thinking, I think, a little bit more creatively about how this message is getting out to people. And a lot of times it's just asking, right? If you see someone out, I just got this done. Have you done this? Did you know that we are supposed to be doing this now? I think that's going to be really important in addition to telehealth. And telehealth is not just for rural areas where it is really important, but it's also, quite frankly, good for everybody, because you just don't know, you would have access to much more through telehealth than maybe you would have if you didn't have transportation, weren't able to get where you were. You can't take time off from work, those sorts of things. So those are really important. I think from like a legislative policy perspective, we would love to see telehealth coverage, extended and made permanent. We are watching very closely Medicaid coverage. That's top of mind for all of us. And it changes daily on what we expect to happen there. In addition to sort of workforce issues. So you mentioned the match and the residency slots and all of that. Like those are really important issues for us. And then just generally funding for research, whether that's getting young scholars into programs that are specialized in particular areas, to also just protecting right now. I use the word protect because I think that's where we are at this moment in time. Protecting things like the offices of women's health and the offices of minority health. They are at risk. I don't know whether they're going to exist. There's still a lot of questions out here, but I think having us all come together to really think about how are we better integrating this across the healthcare system.
Legislatures are still in session.
Yeah.
And so this is the time to be advocating now, right? To be talking to not only your congressperson, but also your state legislator.
And
about
like
this.
call your governor's offices
Absolutely.
too, especially on the front when you're thinking about Medicaid coverage, right? It's not all happening up here. Whether many things may or may not happen here, but you're having your voice heard at all levels is really important to make sure and explaining it to them. Tell them what you're doing. Tell them how you are caring for patients and tell them real stories, because I do think that makes a big difference. They do listen. They have challenges they're trying to deal with. But I do think having those stories to fuel their policy change is really critical. And that's why it's important to come here, but also talk to your state legislators as well.
Absolutely. Before we shift to questions from the audience, I wanted to ask you, Jeanette, we talked about telemedicine, we've talked a little bit about artificial intelligence, but how can we ensure that artificial intelligence is developed and used in a way that actively combats bias and promotes fairness in patient care?
Yeah, well, I think that we all know that you have to include 100% participation by like consumers and patients. Like if you're going to create it, you need to engage consumers and patients from the start and 100% of the way through development. We've seen that recently some really sad developments actually that the Department of Health and Human Services is no longer accepting public comment on pending regulation during this administration. It's another blow to its engaging with patients. The FDA has long had a history of doing patient engagement during the drug development process and approval process. And when I was at CMS, I actually was part of the organization to help ensure that we had our stakeholders engaged in public comment on all of the Affordable Care Act regulations as we were implementing them. And so for us to be in this environment where the government is creating policies, they're obviously going to be regulating AI, within the industry, overseeing everything. And there is now no longer a way to comment or even engage with the administration. Now, we could say that those who are in the Beltway or who can get to DC and have connections can do it, but that's not an equitable or way to drive policy, right? That leaves out those people with disabilities that can't travel, people with rare diseases that are immune deficient, people that can't travel. And so you have to always include an accessible and an inclusive way to engage populations in this development of AI. I hate to say the saying is that garbage in, garbage out, right? I mean,
I have it written down right here.
Yeah. Yeah. And so, maybe people should be taking implicit bias training and doing that before they're engaging in coding. So there are a few things we can do, but it's almost as if you're going to check the box unless you have like the real consumer, the real patient there at the table, at all levels of engagement, at all levels of development, so that you can get that, what we call the sounding board or the validators. When we develop research tools, right, we want to make sure that we have the validators, right? You have to sort of test your focus group. And so it's just clear that AI needs to really be, have all members of the community at the table.
So let me
Yes,
just take
Dr.
it
Kane,
and
go
talk
ahead.
about this artificial
Yes.
intelligence. You heard of something called prior authorization for a condition, a medical condition. And yet when we see our vulnerable populations or disadvantaged populations, you may have a insurance company have a algorithm in terms of what they do in terms of the denials. And you say to yourself, whoa, how did they develop an algorithm like that? Because I'm having like 2 or 3 denials for this. Maybe I need this surgery on my back. And I'm telling you, well, no, you're going to have someone inject you with some pain medicines in your spine at least on 3 separate occasions before you can have that laminectomy. But hey, that bone is pressing on my nerve. I've got burning pain, tingling sensation. And yet, if this is not resolved, I'm going to have permanent numbness or paralysis with my leg. I can't wait for those 3 injections, lumbar spinal injections for the pain. And I say this personally because I'm a sports fan, right? I have a little kitten on the 2nd floor that bit the hell out of my foot. I swiped them out the way, but I fell down a flight of stairs. And so I herniated my L3, L4, L5 of my spine. I tore my lateral and medial meniscus of my right knee. I tore my right rotator cuff, shoulder, and I tore my left rotator cuff, shoulder. Okay? That's 4 surgeries, right?
Did the Tylenol work?
So he
started
is
with the
going to
Tylenol,
bring
Dr.
up a
Benjamin.
good point, okay? So I went to the emergency room, had to call an ambulance. It's good to know that you know other doctors. So I knew the director of the emergency room to send that ambulance for me. But they treated me, they sent me home within 24 hours. And I want you to know that the medicine they put me on, I was in such intense pain on that bed. I couldn't move. And I says, oh my God, I can't drink no water or anything because I can't afford to go to the bathroom. I'm going to die. But I called to get an appointment to say, hey, I need to see the doctor. Can I get an appointment? But the response was from a nurse, well, I don't think the doctor's going to be able to increase your pain medicine, really acting like I was pain-seeking person, okay? And so I just don't think he's going to give you that appointment. Now, I don't like to tell people I'm a doctor because I want to see how they treat me without telling them I'm a doctor. But I knew that doctor knew who I was. I said, well, just no matter what, why don't you just ask him and then come back to me and tell me whether I get that appointment or not. But here's what it was determined. I got the lowest starting dose tramadol that you could do. But if you saw the injury that was on my MRI, you said, oh my God, why did they not put you on steroids, a muscle relaxer, and everything? And so we need to use this artificial intelligence maybe in some way to cut out the biases based on what the condition is. All right? But I am disappointed. I did call the Indianapolis Colts to say, hey, have I got a tackle for you? We can make it to the playoffs. I'm the agent. Hire my tackle. My kitten can tackle anything. They turned me down. And they did not make the playoffs.
But I mean, you bring up some really interesting points that artificial intelligence, if done right, if taking into account biases, can actually be helpful.
Yes.
Dr. Benjamin, the final question. How do we make sure that AI will continue to play a significant role in healthcare in the right way?
Yeah, we got to make sure that when they're putting those tools together, that they have people that have a range of life experiences, that there's diversity, equity, and inclusion. Yeah, I did use those three words, and I will continue to do so.
That's right.
In part of the conversation of how they build those tools. As you say, garbage in, garbage out. And the fact of the matter is, until we ensure that the data that goes into these systems are representative of the populations in which they're going to be used on, we're not going to be successful. There's going to be more costs. We'll have overuse, underuse, and we'll get terrible outcomes.
Thank you for that. So we want to know how you perceive AI. So if you'll go to menti.com once again, and you shouldn't have to put you do need to put the code in. Yes. So the code. Okay, you don't need to put the code. Okay, here's the question. How do you perceive the role of artificial intelligence in shaping the future of the healthcare workforce? Improve efficiency and reduce administrative burdens, create awareness about workforce opportunities, replace certain healthcare jobs leading to job displacement. AI adoption in healthcare will have little impact on the workforce. All right, let's see what you all think. Well, that's good. All right, so people are being shy. All right. Well, that's good that most people believe they will have a positive effect. And hopefully, Dr. Kane will achieve what you just envisioned for us with artificial intelligence.
Well, let me just say we got a younger generation now. When I say younger, I'm talking about maybe younger than who I see in this audience. So I'm just talking about adolescents. So unless you want to be an adolescent, you're okay, all right. But they are way more techie than us as we're going older. So when you're trying to do an intervention like HIV or trying to help keep their appointments or whatever, they love the text. They love to communicate their interventions on the phone. And so artificial intelligence will be incredible for certain generations based on their age and educational level. And I think we need to think about the different ways of how to reach out to different populations based on their age. But
Absolutely. And
my mother had a heart attack, and she didn't have the typical symptoms of a heart attack like a male does. So we need that artificial intelligence to also say, give them symptoms like someone having jaw pain, nausea, no chest pain, no left arm pain. Well, you're not having a heart attack. And of course, she was having a heart attack.
right. So, and we saw that with TD Jakes. He talked about he didn't experience the normal symptoms. So thank you to all of you panelists. Let's give them a round of applause. We know we ran out of time for questions, but we do want to continue this discussion. So we'll be happy to continue these conversations during the reception after the next panel. We look forward to more one-on-one conversations. Now I would like to welcome our friends from blackdoctor.org and NMA to lead us in a connecting moment. So thank you so much. Yeah, just leave on.
Testing, testing. Okay. Hello. Wow, that was such a compelling conversation. My name is Taylin Washington Harmon. I'm the Clinical Trials and BDO Pro Editor at blackdoctor.org.
Hello, everyone. My name is Christina Epperson, and I am the Health Policy Manager for the National Medical Association, and I definitely concur. This is one of my favorite topics, especially working with Black doctors all of the time. This is so important. I mean, Match Day was just last week, and one of my closest friends just matched. She's graduating from Harry, and I can't imagine her not being a candidate for a residency spot, or not getting a residency spot rather, as she's such a great candidate. And 4,000 students, that's the reality for them. And it's just so important for us to advocate for ways in which we can lessen that gap.
Yeah, I agree. And the whole time I was thinking about this was, if you train up a child in the way that they're supposed to go, they will never depart. And that's why it's so important when you start early to be able to see that it's possible to be a doctor. It's possible to be a community healthcare worker. It's possible to be Black and look like us and be able to perform and work in this field and help people every single day. So it's important that we're carving out these pathways. So that was such an amazing conversation about that. And what did you think about AI? I mean, I know everybody's nervous about that lately.
And I would be one of those people a little bit. But I have to say, just coming from the Hill actually this morning with our doctors, just going back to training up and teaching people the way to treat us. And so that's why we, as Black advocates, policymakers, physicians, we have to make sure that we are the ones saying, hey, if we're going to have AI, it needs to make sure that it's recognizing the difference between a Black patient from a Latino patient, from a white patient, because we all have different needs. So it can't be a one size fits all.
100%. And actually, I experienced something very similar to Dr. Kane, where she was talking about, the bias when it comes to pain. And it's terrible. And we think that AI may have some bias, but it actually can be a great tool for disrupting bias. If we're looking at, our different bodies and how Black bodies work, we're not going to have certain pain tolerances, especially when that was historically thought that Black people could handle pain better.
Just crazy.
I know. So yes, I'm glad that we're learning how AI can, formally change that. But I do want to introduce the next topic that we want to discuss is around 340B.
Yes, a lot of people's favorite topic, hence the sarcasm in my voice. 340B, very polarizing topic, I will say. I think that I've sat on a lot of 340B conversations. NMA has facilitated a lot of 340B conversations. And the nuts and bolts of it is that 340B started over 30 years ago. And we know that this program was a HRSA-initiated program, and it was to give more access to the underserved. And I think that is everybody's plight in this room, is to give more access to the underserved. And so now we're in a position in 2025, over 30 years later, of, is it still doing what it was slated to do? And that is always the question with 340B. And so I think that to keep it simple, the overarching is, do we reform or do we keep it as is? And so NMA personally, we haven't taken a standpoint on either side yet. We're trying to be a facilitator of knowledge in this space so that we can educate everybody to give a well-rounded opinion. And that's what I'm sure that we will see today through our panel on 340B.
Yes, and as someone myself who's still learning very much about what 340B is, how it affects people who look like us, people who look like me, I'm really excited to learn from our exciting panelists today. So I will bring up our next moderator, Seth Ginsburg.
How about this? Yeah, there we go. Can you hear me? Great, great. Well, good afternoon, everybody. It is an honor to be here because this conversation matters. It matters to patients. It matters to communities, to the integrity of our healthcare system, and it matters to those of us who believe that medicine should never depend on your zip code, your insurance status, or your income. First, a heartfelt thanks to Reggie Ware and Charles Drew for convening today's conversation and to our partners at Pfizer and NMA for helping make this moment possible this afternoon. My name is Seth Ginsberg. I'm the co-founder and the president of the Global Healthy Living Foundation, or GHLF. For the past 25 years, I've been a patient advocate, building platforms that ensure people living with chronic conditions don't just survive the system, but help shape it. And so today's panel is all about 340B. And yes, it is complicated, but at its core, it is a simple idea, making sure resources flow to those who need them most. We're not here to litigate the last 30 years. We're here to imagine what can be possible. And we have just the right group to do that. So with that, as I make their introductions, I'd like to invite our panel to the stage because we've got an incredible panel. And if you were told not to come to the stage by somebody, this is your moderator inviting you to the stage. So Dr. Sharon Allison Ote is not only a brilliant physician and strategist, she's someone who brings heart, depth, and a community-centered lens to everything she does. She's been a national voice for public health equity, and she makes sure the conversation we have in rooms exactly like this one translate into impact on the ground. Thomas Johnson leads ASAP 340B, and if you're following this program, you know that name. He's known for his clarity, his candor, and his relentless focus on how to make the system work better, not just on paper, but in practice. Dr. Gary Puckrin, through his leadership at the National Minority Quality Forum, has helped shift how we think about data, disparities, and decisions. Gary doesn't just speak truth to power. He brings the evidence, the urgency, and the vision for what a more equitable system could actually look like. And to go a little off script, when Gary talks, you listen. And you usually leave with a to-do list. And of course, Samantha Sears, a true force in health policy at the National Consumers League. She brings a critically important and often underrepresented perspective. What these programs, specifically this one, means for everyday patients, for families and caregivers just trying to navigate an increasingly complex system. So with that, let's get the Menti poll back going. Because before we jump into this incredible discussion, I remind you to log in at 144-77095 for this level setting first question. Who is responsible for the 340B program? Is it the federal level, the state level, state and federal? Initiatives directed by healthcare industry, other options like litigation and rebate models, or no reform is needed? Great. Maybe a few years ago, it would have been all federal. But as things are moving quickly, and anyone tracking health policy knows, they bleed into the states. And I think our poll correctly identifies that. Great. Why don't we move on to the second question here? What is 340B used for? To increase access to care for all patients? To help alleviate patients' financial burden due to medical bills? To increase profits for covered entities? Reinvestment in community programs for at-risk populations? Or you just don't know, and if you don't, stick around. Yeah, right. I see quite a, here we go. We've got some voices chiming in here that indeed it is to increase access to care for all patients. Now for the discussion. Let's turn to our panel. I think the best way to open this up is perhaps to go down the list, to go down the row here, for asking everyone what they feel would be the best way to ensure the 340B program is implemented as envisioned for serving uninsured and low-income patients and communities. Who'd like to take that one first? not all at once. Samantha?
Sure, I can tackle that first. So National Consumers League is very much of the opinion that the 340B program needs to be reformed so that its intention is actualized. And there are several ways we can do this, but ultimately it comes down to increasing transparency and accountability for where the funds are going and how they are being used.
Thomas?
I just add that it is a federal program. And I think that Congress needs to look at this federal program and look at some of the practices that certain covered entities have engaged in that we feel go against the nature and intent of the program to serve the underserved, and bring some change to the program so that the program continues its mission of helping covered entities serve the underserved, but also doesn't allow for certain practices to game the system so that 340B is seen more of a profit center for certain covered entities, as opposed to using resources that are scarce for these covered entities, and it's why the program was created in the first place.
You know, I want to start because at NMQF we're thinking about 2050. I know we're having this conversation about this moment, but we got to get to 2050. And here's the point. I want to start with a little thought experiment. I want everybody in the room who can stop their heart to raise their hand. I want anybody in the room who can control their blood flow to raise their hand. And the reason why I'm asking you to do that is because here's the reality. Our biology works on physical laws that we don't control. We have no control over them, absolutely none. Trump doesn't have it. Putin doesn't have it. You don't have it. The guy sleeping in the street don't have it, right? And so what medicine is trying to do is to maintain order in our biology, right? That's what medicine is. It's about keeping us out of the hospital, keeping us out of the emergency room, keeping us from disability, and keeping us from dying, right? And so when public policy and financing is misaligned with our biology, when it is not following those physical laws, it breeds inequities. Absolutely, positively, no question about it, right? And so the moment that we're in is that we now have to begin to align our healthcare policy and financing with our biology, period. That's where the 21st century is taking us. That's where all this beautiful science that we're creating is taking us. But the point of the matter is, we call them underserved, we call them marginalized, because we were leaving them by the side of the road, deliberately leaving them by the side of the road, and we all give permission, and we have this wonderful debate about 340B, right? But here's the point. 340B and any healthcare policy has to be aligned with the science and the biology. And so anybody who wants to argue about 340B, the question you have to ask them is it helping people stay out of the hospital, out of the emergency room, from disability, and dying? And if it ain't doing that, and it's not medicine, it's something else, but it isn't medicine. So the way in which we look at public policy these days as we move into the 2050 is that we have to change the legacy system. That system that we're in right now developed during an era when inequities were okay, when segregation was okay, when we created a tiered system and said, well, the privileged can have it, but the quote underserved and marginalized people, they don't get access, right? That's not the future. Whatever's going on right now is a good moment because it allows us now to build the future, because it creates the contrast. As they stop giving vaccines and they stop doing science and they tell people to take whatever the hell it is they come up with, All of that is utter nonsense. And what it allows us to do is come to the American people and say, here's what I want to do. I want to save your life. I want to save the life of your children. I want to save the life of your neighbors. I want to take you into the 21st century and use the science and technology that we are getting incredibly smart, incredibly smart. And when we take a program like 340B and what we're having this conversation about chasing money, it ain't about chasing money, it's about chasing lives. It's about how do we build that future. So that's the way we think about the problem. We think about the problem in terms of, are we mitigating patient risk? Are we creating order in our medical system that matches the order in our biology? Because when they're misaligned, we're going to have those inequities.
I have the horrible position of following all of these people. And so just to put it succinctly, I do disagree a bit with Gary in that he said it was taking us back to a point of segregation where inequities were okay. Actually, isn't that 2025? I was on 2 phone calls today, and I'm telling clients how to scrub their website so we don't talk about inequity, don't talk about disparities. We change our language. We are at a point of utter chaos. And so certainly not to be political, because medicine should not be political, but it is. And so when we talk about 340B, we talk about the fact that this originally was to help offset rural communities, marginalized communities, communities at risk, and persons that could not afford, or hospital systems that could not afford, pharmacies, et cetera. In its original intent, sounds pretty good. But in medicine, it has certainly, as physicians, we know if you can't measure it, if you can't report it, it did not happen. And that's the problem with 340B. The money that comes in, the savings are now profit centers, not centers to reinvest into our communities and give back to the persons. And certainly there are studies out there, and people would say, well, actually there are isolated times that we can track it. And I want to make sure that this panel, that we're very fair and biased. But sometimes you got to call a spade, right? Not biased, unbiased, right? But sometimes you have to call a spade. And we know that this, while in its inception, was a good idea for many of us, but now in implementation, if you can't tell me where the money goes, I can only assume it's not going back to where it was originally intended.
So we got a lot of work to do. Thomas, spend a lot of your day thinking about this, don't you? Why don't you unpack for us for a moment here, what's right about 340B and then what's not?
Well, I think what's right about it is that it is a program that helps hospitals, clinics, other types of entities gain access to prescription drugs for outpatients at a major discount. And the discount is about 57 to 60%. So, we think that is actually a good thing. And that's why our coalition supports the program. And we want it to continue to serve that population. Unfortunately, when you have smart people that a lot of these hospital systems hire, and they are able to read the law, one thing they do, if you're good at what you're doing, is you look at the law and you look at what it says and you look at what it does not say. And so what's happened is, because there haven't been a lot of changes, there hasn't been a lot of oversight, especially at the congressional level, as it relates to this program. Certain hospital systems, and I'm pointing out hospital systems primarily because 87% of the spend in this program goes to hospital systems. They have engaged in certain practices that have been documented. They've been documented by the New York Times, have been documented by the Wall Street Journal, We have seen instances of a hospital spending potentially as much as $8 million on a Super Bowl ad. We have heard a story of another hospital system spending money to help pay the salary of a football coach. These are the types of things that have taken place because people look at the law and they're able to determine what it says and what it does not say. And so as any program that has existed this long, that is as large as it is, this is the second largest prescription drug discount program in the country, and it will be the largest in the next year or two. It is more than reasonable to take a look at this program, what's happening, what isn't happening, and to correct some of these practices. Because the fact of the matter is, for all of us who care about equity and access, there is money being spent in a manner that is not consistent with the intent of the program. It's being spent to help hospitals vertically integrate, especially in the cancer area, and grow. You know, I mentioned the instances that I talked about previously where it's not spent on healthcare. It's spent to encourage expansion in affluent areas instead of underserved areas and extend the discount to those areas. These are not things that were listed in the statute. And so, you know, the 27 organizations that make up our coalition feel that it is long overdue for a real look at this program and to make some corrections. All we're talking about is making corrections. We're not talking about ending the program. We're in support of the program. But we really think, you know, a lens, you know, needs to be opened and reform needs to take place.
Great. So when I got the invite to be here, this fell over spring break, and I promised my wife, I said, Cara, I'll get you a rose for every time the word transparency is said out loud. So let's hit that dozen, shall we? So I can go home and make it through the week. But I think this actually would be a good question to you, Sharon, Doctor, around transparency in the sense that could you shed a little light on who is meant to be holding accountability here and who is meant to oversee the program and how we're brought to here?
Who is meant to or who does?
Well,
because there's a goal. And so when we talk about, and the other panelists can correct me if I'm wrong, when you talk about certainly overarching HHS, HRSA, the states, you are supposed to be able to, just like you have to document and diagnose and be transparent in how you get there. I think there are several pain points where we should have overarching from a financial standpoint, but also not just the money. We're talking a lot about the money. What about my mother in rural America that's an African-American 84-year-old that would benefit, right? Who is telling me, and certainly we had the examples, and there are many more of football stadiums, of advertisements and all that. What is the patient story? And so just like Medicaid, Medicare has to talk about how much funds are actually going to healthcare providers, to the hospitals, et cetera, all of this should be part of a national audit and a federal audit. And where is that? I haven't seen it. Have you all seen that? I haven't seen it. And the question is, do we really believe, and we're having this wonderful intellectual conversation right now, but do we really believe that in 2025, there will be a shift to make sure that overarching entities that use money, millions and millions of dollars, will all of a sudden wake up and say, let's make sure we go help the little person? Do we think that DOJ is going to come in and say, wait, we've got to jump on this? And so I think by the coalitions and by us holding not only red, but red and blue congressmen and women accountable to say, we do want a national federal audit of this program, and it does need to be reformed.
That'd be a good start. Gary, let's have you weigh in a little bit here. How could we address these concerns around transparency?
So first, let's try to understand what 340B is. It's actually a tax. It's a tax on the pharmaceutical companies. I mean, that's what it is. It's a tax. The interesting thing, it's a tax that the federal government set up, but what's interesting about it, talking about transparency, it's not audited, right? So you got tax dollars running around that are unaudited, and guess what's going to happen? So really, really bad stuff is going to happen. So we work on the ground. We go into communities in Flint, Michigan, and Third Ward in Houston, Texas, and Cancer Alley in Louisiana. Those people do not get access to best modern therapy, even though the hospitals get 340B money, but they tell those folks that they don't have the money, and if they give them the drugs, they end up with medical debt. That's the program, right? And so when you push back and you say, well, wait a minute, where's the money? As my father would say, they call you everything but a child of God, right? And so the point I'm making, I think where Seth is trying to take us, is that you got to have audited financials. When you start moving that kind of money around, you just, it's not good, it's not healthy, it's not good financial practice, right? Particularly when those dollars are supposed to target particular populations. Now, my friends in the healthcare system, hospitals will say to me, no, that's provider money. That money is intended for providers, it's not intended for patients. That's what they see that program as a tax that brings in money to them that they can use. And that's what they fight about and call us all kinds of bad names. But here's the point. Talk about cancer. African Americans have the highest level of cancer in the country, have the highest mortality for cancer than any other population in the country, followed by Hispanics. They get metastasis, they get diagnosed late. The cancer is metastasized. They don't get access to best modern medicine because the money is not there, and the system says to them, we can't afford you. And so when we look down at the community level, what we say to them is, you need to go have a conversation about that 340B money. Let's go talk about that 340B money, because that's the money that can help you get the access to the medications, save your life, save your child's life, because the system right now is turning a complete blind eye to what's happening in those communities.
Thomas, let's talk a little bit about what the impact of 340B reform could be on graduate medical education.
I don't know if there's a direct relationship between the two, but what I would say is this, and I want to echo something that Gary raised. This is an example of what's being going unchecked with regards to reform, and I just want to read this. So there was one report that found that a 340B eligible hospital marked up a cancer drug 10 times the list price, received insurance reimbursement at nearly 4 times the list price, and then they still sent a $2,500 bill to a senior with metastatic breast cancer. So, you know, these issues about medical debt, which the National Consumers League has done a great job in documenting. These issues about charging 500% or more of a drug that you acquired at a 50% or more discount for one person, when frankly, you could have taken that same money and taken care of 5 people. Okay? So any program related to healthcare that is misusing dollars in this fashion, that's supposed to be for the underserved, not only deserves a national audit, like was brought up, but also needs reform to make sure that these types of practices do not continue.
Seth, can I just say one thing? By the physicians in the room, how many before you got the flyer for this session really were aware of 340B programs? Tell the truth, shame the devil. How many were not, right? Now, the scenario that he just brought up, what would happen to your colleague if you sold a sample in your office? We'd be in jail, right? You get an orange suit. That's how preposterous this is. When we talk about fraud in the medical system, we often want to look at those of us with an MD or a DO behind our name, but think about the example that he gave. And what happens if America really knew that this could happen at a hospital in our already desert poor areas that are to help us? So I'm sorry.
Oh, that's all what this is about. And as I like to summarize it, the American healthcare system is summarized in the 4 characters of 340B. So dig into it. Let's turn to you, Samantha. Let's talk a little bit about how community members, especially to those tuning in online, especially and learning a little bit about this today for the first time, how can they advocate for themselves around this topic?
Yeah, that is a great question. And I think it's something that community members need to be more involved in, because even in this room, not very many people know of the program. And when I talk to my colleagues at other organizations who are also involved in this, many of them are just as confused, because it has become a very complex and convoluted thing when ultimately it was established to, as we've said before on this panel, increase access to care for underserved and uninsured and underinsured patients. And I think one of the things I really want to stress coming out of this is that patients, regardless of their insurance status or other statuses, cannot access what they cannot afford. And so one of the ways we have gone about advocating for change is through the relationship that patients have with medical debt and how these hospitals and other entities in the program are collecting on it. So we did an analysis of collection policies at, I believe, just hospitals, but we found that 340B entities and 340B hospitals were significantly more aggressive in their debt collection policies than any hospital type. And this was about 80% to 20 or something. It was jarring how drastic it was. And 340B hospitals and other covered entities are also nonprofits. Nonprofit hospitals have to provide charity care. And so working in your communities to increase education around your hospital and your clinic's charity care status, as well as how to go about collecting it and to accessing it, because these are not well-known programs within the communities. That was the word I was looking for. I think is a great way to start highlighting the issue that we have talked about ad nauseum amongst ourselves here, in that there is a misuse of funds and ultimately the patients are suffering for it.
Churchill once said, if you've got a difficult problem, the best thing to do is to make it bigger. And I want to make this problem a little bit bigger for us, right? So America spends $4.5 trillion a year on healthcare. $4.5 trillion, about 22% of GDP. The GDP of France is 3.3 million. The GDP of Germany is 3.2 million. Trillion dollars. So everybody in France working every day do not produce the same revenue that we spend in healthcare. The problem is we have no idea where that $4.5 trillion is going. We talk about 340B, but we have to have a deeper conversation about that $4.5 trillion because we got a lot of folks inside that $4.5 trillion that are not delivering quality health care. And so $4.5 trillion, and we tell Americans, we don't have enough money to take care of you. We can't afford you. We got to have that copay. We got to do this, right? And what I'm saying is the problem is not just 340B. As we start to really get ourselves towards mid-century, we cannot take this healthcare system into mid-century because it can't support the medical revolution that's in front of us. We are in the middle of a medical revolution. We will control cancer by 2050. Absolutely, no doubt about it. The business model for cancer will completely change because we're going to start diagnosing people when they're precancerous, before they're symptomatic, before the tumor is formed, right? And guess what? We can actually do that right now. Literally, we could do that right now. But what we say, we can't afford that. That's my point. So talk about an assignment. The assignment is, let's give ourselves permission to reimagine this bad boy. Let's have that deep conversation. All that stuff going up on Capitol, that's ridiculous stuff. I don't even know where them. I think aliens made a jump down there. So I don't know what the hell is that. I don't even know what that is. That's beyond silly. That's crazy, right? But the rest of us have now got to think about the future and what we want to build, because we can actually do this. And 340B is part of it, but there's a broader conversation to be had.
Sherry, lock the doors. We're in this room till we figure this out.
That's a no.
And coming back to, Samantha's comment, I have the privilege, I travel around the world, and you mentioned France and Europe. Anytime someone overseas asks me about the US healthcare system, I immediately default to the concept of medical debt. And the looks on their faces, they just don't understand. And it is one of the most real, one of the most taxing and truly treacherous facets of our system. But let's try to now really, I guess 10 or so minutes we have remaining. Let's hash it out. Let's try to figure out how to meet in the middle here. I'll stick up for 340B for a moment, if I may, and say the best thing about it is its intent. Dare I say one of the top 3 things Bush Sr. did during his admin? Maybe. They really had the intention to make good for a huge problem facing America, especially in rural America, but all over America. And amazing how far we've driven off the rails, isn't it, over these 30 years? But should be no surprise, given how dynamic and, to Gary's point, it's trillion with a T dollars involved, and thus it's important that we meet in the middle. So I put this to the whole panel. What is that middle ground, and what could that look like for positive, meaningful, productive reform?
Well, in order to reform, first of all, you have to diagnose the problem. You have to have all the data. So let's just start with an audit. Let's start there. And I want to be very clear. I am not saying that all of 340B programs are horrible and that all of them have overspending or other nefarious is the word that I was looking for, intent. I'm not saying that. I would dare say that, and unfortunately, because we don't have the data, I can't give a percentage. If I had the data, I could say 60% or 40% passed an audit, et cetera. We don't have the data. So let's start at the beginning. Number one, it was a system that was put in place, a policy put in place with good intent. Let's see what happened with that good intention, positives, negatives, and everything in between, and then make the diagnosis and a course of action. In that way, I'm a strategist. One, what's the problem? All right. And now how do we solve? But we're trying to solve a problem that we really don't know the depths of the highs or the lows. And let's bring everybody to the table. NMA needs to be at the table. Healthcare, other healthcare organizations need to be at the table. Advocacy groups at the table. Pharma needs to be at the table. All of us together saying the intent is there. I don't think any entity would say, oh, in principle, 340B doesn't make any sense. So now, how do we make sure that it meets the needs of the communities that's supposed to serve? So let's have a diagnosis.
So I'm a street guy. I'm sorry. I grew up in the community, right? I'm just telling you the truth. I believe we got to go educate those folks in the community so that they can vote appropriately, period, right? Because we're having this intellectual conversation and I love it, right? But down there in the community where the folks need 340B to work for them, nobody's talking to them, right? You're not even talking at them. You're not even going down there and trying to figure out what the hell. So, excuse me, get in the car, drive down to the community, and begin to talk to them about their life experience. It's shocking. It's absolutely shocking that we give permission to have civil society do that. Shocking, right? So I'm for going down into the community. I'm sorry, man. I grew up down there, and those folks need to hear some trusted voices say to them, I understand, and we're going to work this out together, and we're going to bring the folks at Sharon, but we're not going to do it here at DC. We're going to do it down there with you so that you can understand what exactly is going on. And then finally, what I'm saying, because a whole nother part of my life, I lived in academia. I was 35 years old before I left the class. I don't even know how the hell I got out of their classes. but here's the point. You have to have an intellectual framework, right? You just can't operate without a system so that you have strategy and tactics so that you know what you're doing. So we need to take a moment and build that framework so that when we go down to the community, we can tell them what that future looks like, right? That's what they're asking you. Tell me what my future could be. Help me to get there. That's the exercise. But in order to do that, you have to take a moment yourself. How many of you actually have a plan for our healthcare system? Do you actually know what the hell we're doing, why we're doing it, where we're going? The answer is probably not. You go up there on Capitol Hill, ask them. All you guys like to do those flyers, go there and do a flyer and ask them, what the hell? What are you trying to do? Cut Medicaid? Oh, that's a strategy. Medicaid? Oh, that's a good one. Get rid of vaccines? Oh, I love that one. How about we get rid of NIH? Let's cut the workforce. What the hell? Is that the future? Is that what America is buying into? I don't know, okay? So anyway, 2 steps. 1 step, let's think about what we're doing and why we're doing it. Next step, let's go down in the community and build the grassroots so that, because it's democracy, right? It's about the vote. So let's go do some democracy and reframe this conversation.
So I'm going to give a 2-part answer, but I'm going to try and keep it short. And the first part is that, the first group that I talked to when I started this journey with this coalition was a group of ministers in New Jersey, African-American ministers. And I can tell you that 90% of their audience did not know what this program was. So I think part of not only my role, but others who are interested in this issue is don't just talk to the people in healthcare. Okay, talk to the people in the community, as Gary was saying, because they need to know what's happening with this program. Like I said, in a year or two, this is going to be the largest prescription drug program in the country. And it makes no sense for there to be little to no transparency in this program. That makes absolutely no sense. Now, speaking of which, I'm going to identify 3 areas that I would say, generally speaking, the conversation should center around. One, I have worked with African-American physicians my entire career, locally and nationally. And one thing I will tell you that all of them have in common is that they want to know what is in the best interest of the patients that they serve. So my question is, how do we get this benefit to make sure that it acts in the best interest of the patient? Okay, we already know by definition in the statute that covered entities receive the benefit in terms of the pricing within the program. But how do patients specifically benefit from this program? That should be something that should be identified clearly. The second is that we have to come to an agreement on transparency within this program. I'm not going to repeat the things that have already been brought up because there are many more of them. There are many more stories like that. But, I frankly even think the leaders of the hospital community are embarrassed when they see some of those stories that have been reported on, like in the Times, in the Wall Street Journal. And having run a trade association myself in the past, I can tell you I'm embarrassed when a member of my association engages in activity that makes the entire industry look bad. So why don't we try and agree on some transparency measures so that not only we know what's being spent in this program, but also the industry itself can look better and not have to look bad because there are a number of actors that are abusing the program. The last thing I would say is these other practices, medical debt, these child sites, let's again try and come to an agreement on what should we do in those areas. But the conversation, frankly, has to bring the hospital community to the table. And to date, they are not willing to come to the table.
Yeah, I echo everything that's been said in regards to how we can fix this. I also think it's really important that when we are educating our communities about this program and its goals and intentions, we're also educating our members of Congress and our policymakers, because it is a big old question mark with them too. Most members of Congress don't really know about this program. They don't understand it. Most of us in the policy side of this world don't really understand this program for some reason. And so I think just in our conversations and in our advocacy, ensuring that there is clarity and transparency, to add to your wife's roses, in the language used and in understanding the program, and outside of just its tensions, but its actuality and its how it actually does what it's supposed to do.
There's a lot of promise in this program. And with reform, that promise can be realized and people can get the care they deserve in America, hopefully fewer than 25 years from now. I know we're short on time here, and far be it for this panel to be what's between this group and our networking and cocktail reception. So I would like to take the opportunity to thank the panelists. I think we have one more mentee. Yep. Thank you. Let's turn this conversation into action. With your phones, please let us know. How do you plan to use your voice and act in the 340B discussions? So we're talking about learning about all sides of the 340B discussion, reaching out to legislators, learning how to use my voice in local states, raising my voice, requesting leading organizations to take a position, which would be good, or you don't plan to participate in 340B discussions, and if so, you're paying for your drinks. Great. Well, this conversation is the springboard to action, hopefully to reform. To everybody in this room and everyone tuning in online, thank you for the opportunity to have this really important conversation. Like I said, one that matters to patients, one that matters to the community, and one that matters to all of us. So with that, transparency, 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 and thank you very much. I believe so. So thank you. And then we'll probably want a picture of all of us. And after that, we'll invite up Joy Calloway from NMA to close us out. And thank you again to BDO and NMA and Pfizer for convening today.
Now, I'm the only thing between you and a cocktail. And I'm the daughter of a preacher, so buckle up. Good afternoon, I'm Joy D. Calloway. I have the privilege, the honor, and almost always the pleasure of being Executive Director of the National Medical Association. As the opening day, Hill Day of our colloquium is coming to a close, I want to take a moment and pause and just reflect on what it really means for us to be here, Black physicians. No, I would have used it. Together in our capital. Thank you. This year's colloquium theme, as we know, focuses on transforming population health, but we know that this whole time together is really a continuation of the amazing work that this organization has done since 1895 through I don't know how many administrations, right? So we're not going to let an administration slow us down. As the nation's largest and oldest organization representing Black physicians, we are representing the interests of the more than 50,000 Black physicians in this country, their patients, and their communities. And we have over 100, I think I have 125, I got to do the count, affiliated societies throughout this nation and U.S. territories. We have over the years become known as the nonprofit, nonpartisan, but not neutral, voice of health in Black America. Our enduring strength lies in advocating for diverse representation amongst physicians and healthcare professionals, inclusive training for physicians, and equitable, we're not afraid to use that term, equitable healthcare for all. In my 30 years of healthcare experience, I know you are like amazed, 30 years. Public health, healthcare, nonprofit leadership, I really have seen remarkable changes and advancements in medicine, in technology, and in healthcare across our country. It has been very gratifying for me, even as a younger healthcare professional, to see all of the ways that Black Americans have overcome centuries of discrimination in public policy, financial practices, societal norms, even as some of those in power might want to kind of brush those away or make us forget about those things. But the strides that we have accomplished have been remarkable. We've made admirable progress in all of these areas, but unfortunately, the disparities in health and wealth affecting Black Americans remain. Today, we find ourselves in a political and social climate that threatens to widen health gaps in our country and roll back the clock on our progress. And this is of great concern to the National Medical Association and the staff that support its great work. In January, for example, the Association of American Medical Colleges reported enrollment of first-year Black and Hispanic medical students fell sharply, as you can imagine, following the Supreme Court's decision that struck down affirmative action, which was put in place to right the wrongs of the past, not to do anything special for Black folks. According to the AAMC, more than 11% fewer Black students and 10% fewer Hispanic students began their first year at MD degree granting institutions this year over the previous year. When we consider that currently only 5.7% of physicians in this country are Black, it's clear that this trend is going in the wrong direction. We know that more diversity in the physician workforce builds trust. It enhances the physician-patient relationship, and research has shown it improves the health outcomes of not only that patient, but all the patients in the community, regardless of their color, when there is a Black physician in the midst. And it results in better health outcomes for that entire community. This is kind of a pregnant pause, and I'm turning the page. In addition to the troubling lack of representation in medical fields, health and wealth inequality endanger the very lives of people of color in this country. One other example, in its December 2024 report on health inequality and economic disparities by race, ethnicity, and gender, the National Bureau of Economic Research compared Black and white health in terms of frailty. This shocked me. If you've heard this, let me know. This felt new to me. Frailty or health deficits, as you all know. At age 55, Black men have the same frailty as white men who are 13 years older than them. Any 55-year-old brothers in the room? And Black women at 55 or 57 have the same frailty as white women 20 years older than us. That is staggering. And they far outpace the figures for Hispanic men and women. So it's us that are the frail ones, or so they think. As a nonprofit, nonpartisan organization focused on health equity, we know that achieving our mission requires exploring and working towards solutions to longstanding structural, racial, environmental, and financial barriers. And I'm closing like this. Now more than ever, representation matters. We have to be in the right places, saying the right things, with the right facts and data and stories to the right people. And that's what Hill Day is all about. That's what this colloquium is all about, working with our elected officials and other leaders to send the message that inclusion and representation is essential. It's a business imperative in order to improve the health of our nation. I'm really so pleased to see so many members today standing in solidarity with the common messages that we were sharing on the Hill today. These partnerships and this education that we're doing, it's integral to our very mission of improving the quality and availability of healthcare to underserved populations. So I really thank you for being here at this year's colloquium. This day has already been great. We thank you to our partners at BDO with Pfizer's support, NMQF support for this afternoon's summit. We are looking forward to having a really good 3 more days. This is just day 1. And with that, I will again thank you, welcome you to the 2025 NMA Health Policy Colloquium, and I'll cede the floor to our next speaker. Thank you.
Okay, so at the beginning, I said we're going to do 2 things, educate you and encourage you to action. So I want to know, did we deliver on one of those 2 things? All right, so y'all don't have to come find me later. Thank you for being so attentive. I just wanted to say a couple of closing remarks and some of the takeaways from today's panels. I think we all agree that healthy communities bring strong economies. We hear a lot about fraud and savings. We don't want to be the source of creating these gaps. We want to make sure that people understand we're not doing any of this because it's the right thing to do. We're doing it because we want to make sure that our populations are healthy. We heard a lot today about education and policy and advocacy. And so I want to encourage us all as we leave here today to understand the data to support all of the arguments that you want to make. No one wants to have a feel-good story just to have for the sake of a feel-good story, but there are data that are out there. NMQF is definitely leading the way on finding information about communities, and we should be partnering closely with them to understand how we can shore up our arguments. And then we also want to have stories because there are real people behind all of these things. We don't want to just hear 10,000 of this population, got diagnosed with this. We don't want to hear that 10,000 people are losing their job in this part of the government. We want to say, Melissa from Alabama is not going to be able to do X, Y, and Z because of this change. And there are 10,000 more Melissas out there. So have your data, have your stories, understand who is in your legislative community, who you need to be talking to, the organizations that you can work with. Sometimes people think that they have to be, the next Martin Luther King Jr. to get something done, but we don't. The 4 blocks that surround where we live are where we all need to start. That's all we have to do. Make it small. The elephant is big, small bites. So get your data, get your stories, and get going. Thank you.
All right, I am the last speaker of the day, and I'm just going to be very, very brief, but I do want to, first of all, thank you all for attending. I felt it was a great, not only a great conversation, great discussion, but also I think, and maybe more importantly, the example of leadership, right? Leadership is when you're moving in the right direction, and no matter what the circumstances and the situation, no matter what the circumstances are or how the situation changes, right? You stand where you are and you move forward because you know that that's your call, that's your purpose. And so I want to thank Pfizer, right? Because pharmaceutical companies are, they're being asked to do a number of different things that, a lot of us could disagree with. But then you've got the ones that are standing tall and showing and exhibiting leadership. And so, first of all, let's thank Pfizer. Give them a round of applause. The other people we have to thank is the NMA, the first and the oldest Black organization in America is the NMA, right? The doctors. They led back in 1895? My goodness. And they're still leading today. And they're demonstrating that leadership with the colloquium that we have today and all the other things that they do. And of course, I want to thank Gary Puckman's organization, National Minority Equality Forum. These guys be on the front lines every single day, making it happen. And last but not least, blackdoctor.org, we call ourselves BDO. This is our 20th year. And I'm Reggie Ware, I'm CEO of Black Doctor. And, I started the company 20 years ago because I looked around and said, what's needed? What's really needed? How can I make a difference? And started looking at health and started looking at the plight of Black people. And I started looking at, my background has been health. Those of you that know me know that I started a magazine years prior. It was called Heart and Soul magazine. It was the nation's first health magazine for Black women. Okay, so that was me, right? And so I'm sitting back and I'm relaxing, I'm playing golf and I'm hitting a golf ball. And then I get this, and I'm hearing this thought, you've got to do something else. You've got to make a difference. You've got to have a purpose. And so I created this website, blackdoctor.org, right? And the reason I called it Black Doctor is because, when you talk about health and Black people, the safest, warmest, most loving thing you can say is Black Doctor. Because what does that mean? A person I can trust. Somebody's got my back, somebody's going to break it down to me, all of these wonderful attributes that help us in our toughest time. And so as a consumer health website, Our name is Black Doctor, and that's why, because we want to let our audience know that we've got the trust in it. We're going to give them information that they can trust. The other thing I'll say is we started this event, Top Blacks in Healthcare. And the reason we did that is because we've got to write our own history, and we've got to make it so that it can't be erased and it can't be modified in any way. And so we started recognizing the leaders in the field. And so we're celebrating our 10th year anniversary next month, April the 10th, and we're doing it in South Beach, Miami. We've got 2 people that are going to be honored in Miami. Dr. Virginia Kane, could you please stand? Dr. and Aisha Foster from Pfizer. Aisha, could you stand? Yeah, okay. Hey, they're being humble, but you know, it's so important that we showcase the people that are putting their head down, doing the work, right? Because that's their calling, that's their purpose, and they're helping to make the world a better place. And to the extent that all of us in this room do our jobs well, man, we're making the world a better place. And with that, I'll say thank you all, and let's have a good time with the reception.